Hello. Hello. I have a pleasure in welcoming Dr. Shivaji Thakre. Dr. Pankaj Ingre informed me that there is some emergency in the family, so he had to rush to Wardha. So he will not be able to join. And we have Dr. Shivaji Thakre and
Yes, sir.
Rajkumar Patel. Dr. Patel is practicing at Sagar, so we take this opportunity to welcome him also for this. We'll start in 10 to 15 minutes.
Hi, hi, Dr. Patel. Hi, Shivaji. So you can unmute yourself. Thanks for logging in.
Good evening, friends. A warm welcome this evening for the Midas clinical meeting. This is 103rd clinical meeting organized by Midas Medical Foundation and Hospital. Today, for the first time, we have changed the venue. So maybe there people might join little later. And it's a hybrid meeting. So many people have joined online. We have many cases. So I personally request the chairpersons, especially Amit Agrawal, who is staying here, to please occupy the chair and restrict the discussion so that, the time will be allotted to each case. Amit, may I have a pleasure in inviting Amit for as a chairperson, along with Rajesh Singhania, who is joining within 5 minutes, Dr. Padole, both Padole, Pratik Padole. Pratik Padole has done DNB gastroenterology from Gangaram Hospital and is practicing gastroenterologist at CRIMS. Dr. Senior Surgeon Padole, everybody knows. Dr. Singhania is the director of BIMS, that also everybody knows. The online chairpersons, may I have request, may have a pleasure in welcoming them. Dr. Pankaj Ingre informed that there is some emergency, so he has to leave to Wardha because his brother got a massive MI. Rajesh Kumar Patel, welcome, dear Rajesh.
Thank
He
you,
is
sir.
one who has done DNB from Gurugram, UP, and he is practicing gastroenterologist at Sagar, MP. And then we have Dr. Shivaji Thakre, who has done,
Thank you, sir.
who is a consultant gastroenterologist practicing at Akola. He has done DNB Gastro from Global Mumbai. So, with this brief introduction, I would hand over the mic to Amit for further proceedings.
So, welcome to today's 103rd Midas clinical meeting. So, by the time our rest of the chairperson come, we can start this meeting. So, we have today lined up around 5 cases, and these are very interesting, definitely going to be interesting cases. So, first case is rare colitis. So, we have 3 cases of rare colitis. It was presented by Dr. Ravi Daswani. Now, colitis is quite common. We often see patients with colitis, and fortunately, most of the patients have mild disease and they very well respond to our routine medical management. But sometimes it's very challenging. Patients are admitted for weeks, and after some time we don't find any cause, and most of the time it seems very difficult to treat such cases. So I hope all these three cases are going to be very much interesting. Dr. Ravi, please.
Thank you, Amit sir, for this kind introduction. I will be presenting two cases, and one of the unusual colitis case would be presented by Mukeva sir. Uh,
Recording in progress.
These two cases are common cases in the clinical practice, but the diagnosis is uncommon, which makes them unusual today. This is a 38-year-old female who was admitted with us with history of loose motion since last 2 days, 2 months, and she had frequency of 5 to 6 per day, which was large in volume, had urgency with no blood. She also had crampy abdominal pain with occasional nocturnal frequency. However, there was no history of anorexia or weight loss. She had history of hysterectomy, and there was no history of NSAID abuse. Her history was also negative for any systemic disorder like diabetes. On routine evaluation, the blood investigations were fairly normal. IgA TTG was negative. Stool examination on a routine macroscopy showed no abnormality, and ultrasound abdomen as well was normal. We did a colonoscopy, which was essentially normal, and we took multiple random biopsies from both the sides of the colon. Uh, on the histopathology, we found this, and I would like Ravi sir to have a word about it.
This is a very beautiful slide which any pathologist would like to see. And this here you can see the mucosa is almost normal on the left and the lower part, almost normal with minimal crypt, some crypt changes which is so minimal that it could have gone as normal. But on the right side on high power you can see there is a collagenous band. And this collagenous band is so beautifully seen, and it is very easily more than 10 microns. And that is why the diagnosis, and also there was mild inflammation in the submucosa, which was also minimal. So this we diagnosed as collagenous colitis. And although as a student, we used to always talk about collagenous colitis, discuss about collagenous colitis, but it's a pleasure for a pathologist to make a diagnosis of collagenous colitis. The issue is sometimes you have to take biopsy from 2-3 sites because you may not see collagenous colitis in one site. I think there are some standard protocol from where you take the biopsies. Also, if it is less than 10 microns, then it becomes subjective. Sometimes you end up calling it incomplete collagenous colitis. And this incomplete collagenous colitis is a very subjective entity. Like, unless the clinician tells me that everything is normal, and if I see some patches which is 8-9 microns, we have a micrometer, we measure this also, and we have a special stain which we had done it here, Masson's trichrome, which gives the staining for collagen. So this we diagnosed as collagenous colitis. I think Ravi will tell you. I could not get the picture but we do in my setup, Institute of Surgical Pathology, we routinely do pass and Masson's of practically all, even all liver biopsies. In liver biopsy, Masson's is, this was almost 12 microns at places, 12, 13, 12, 13. So this was very classical collagenous colitis. Most of them were lymphocytes, occasional polymorph and eosinophil, but not significant. And sorry?
No, we can have questions at the end.
Maybe after, sorry, you can ask.
Okay.
So we treated this patient on SOS low pyramid, and patient was clinically fine and was doing well on telephonic follow-up. This is another lady who is 43-year-old. She presented to us with periumbilical pain for last 2 months with intermittent diarrhea. Frequency was 6 to 7 per day, small in volume, mucoid with no blood, with no nocturnal frequency. Her baseline bowel frequency was around 1 to 2 per day, and she also did not have any weight loss, had normal appetite, and clinical examination was unremarkable. Again, routine evaluation showed a normal hemoglobin, albumin, thyroid profile, and was all again was not contributory. ultrasound was normal, and stool routine did not show any ova cyst of any pathological significance. Did an endoscopy. We looked for changes of celiac disease. This is not so well prepared stomach, food residue seen, but we took duodenal biopsies here, which turned out to be not significant, not specific. We also did colonoscopy, which was essentially normal till terminal ileum. And again, we took biopsies from both right and left side of the colon. With symptomatic management, her pain decreased, diarrhea episode persisted. However, over the time, these episodes also subsided. The histopathology showed.
So obviously you can guess if the first case is collagenous colitis, this is going to be lymphocytic colitis. And that is what it was because colonoscopy was normal. However, there were many findings in our endoscopic biopsies. And there were plenty of lymphocytes. There were some lymphoid follicles also, but these lymphocytes, intraluminal, intraepithelial lymphocytes are there, and they were easily more than 20 per 100 enterocytes. And that is what is the diagnostic criteria of calling it lymphocytic colitis, and there was no collagen band. Sometimes you may see a collagen band as well, but usually that is less than 10 microns. Here it was, and this sometimes you may normally also get lymphoid follicles in the colonic biopsy also, but as a rule, these lymphocytes are not in continuation with those lymphoid follicles, and that is one of the criteria. Once in a while, if you are not sure, you have to do CD3 stain, which is not always done. CD3 is a T cell marker, and that is sometimes diagnostic, especially if you are in a doubt whether you are dealing with lymphocytic colitis. But then this was very classically, there were plenty of lymphocytes, easily more than 20 per 100 epithelial cells. See, this is a lymphocyte. This is a lymphocyte. This is a lymphocyte. So in the mucosa, you start seeing lymphocytes actually. More than 20. Because if it is less than 20, then it doesn't fit in. There is one condition which goes, of course, which goes as checkpoint inhibitor colitis. This checkpoint inhibitor colitis is seen in, you will see almost features like this. But what is meant by checkpoint inhibitor colitis is patient who is on immunomodulators or monoclonal antibodies for some malignancies. Here, the history is very important. Like I always tell my colleagues that in gastroenterology, in non-neoplastic conditions, it is the clinician who gives the 90% diagnosis. Like what you see, I am supposed to confirm it because so many times it is very difficult for us to independently make a diagnosis that yes, this is only lymphocytic colitis. Like in this case, there were no clinical findings. Colon was normal. And CD3 is done in only doubtful cases.
To continue further, the patient got better. As the patient was asymptomatic for diarrhea, she was not started on any specific therapy. Telephonic follow-up, 2 days back, patient was stable with no further diarrhea. She had gained weight of 2 kgs with mild dyspeptic symptoms. I'll just brush through some review about the microscopic colitis, which is chronic inflammatory disease of colon that is characterized by chronic watery non-bloody diarrhea. The median age is 65 years with female preponderance, but 25% of the patients of microscopic colitis can be less than 45 years, as the first case was. The usual uh, uh, thing is these patients are associated with some autoimmune background. HLA-DR3 DQ2 gene is also present in these patients, and which is also a predisposing factor for celiac disease. And 2 to 9% of these patients can have small bowel changes of celiac disease. Most important part in the history is any intake of NSAIDs, PPI, especially lansoprazole, statins, SSRIs, and drugs like pembrolizumab, which increase the chances of patient having microscopic colitis. Smoking increases the risk by 2.1 times. The The mechanism is mucosal inflammation in principle. However, there can be sometimes an osmotic component, as in few of the patients, when the patient is asked to keep fasting, the frequency of stool decreases. There is a active secretion of water with the sodium and chloride, and hence it is more of secretory diarrhea. There is also a theory about the concurrent bile acid malabsorption, and hence the role of cholestyramine in the treatment. Clinically, the patients would have insidious onset chronic non-bleed diarrhea, which is around 4 to 9 stools per day. They have some association with fecal urgency, incontinence, nocturnal episode, and abdominal pain. Associated weight loss could be due to fluid loss or decreased oral intake, and rarely these patients can have extraintestinal manifestations. And hence, our clinical differentials include IBS, Crohn's disease, and sometimes SIBO as well. Workup, routine blood evaluation, and stool examination is essential. Endoscopic evaluation is just to confirm that there are no major ulcers or pathology. Microscopic features include slight edema, erythema, friability, with occasional exudative lesions and scars. However, there is a huge observer variability amongst these macroscopic features, and hence one should take separate samples from both right and left colon. The disease is patchy, and there comes the role of chromoendoscopy, and where we can use to highlight the mucosal alterations. Confocal laser endomicroscopy is a promising endoscopic tool which can be used in such cases. As sir has beautifully demonstrated, there are three variants. One is lymphocytic, second is collagenous, and third is which doesn't fit into either of the two. So if the IELs are more than 20, it fits into the lymphocytic variety. When the subepithelial collagen band is more than 10 mm, it fits into the collagenous. And if it doesn't fit into any of the two and has both the changes, it is non-specific. The goal of the treatment is to achieve clinical remission, which is less than 3 stools per day with no watery stool in 1 week period, and improve the quality of life, which is the most important part. Diarrhea may resolve within weeks with or without the treatment, and hence one has to follow up these patients closely. But relapses are common. General measures in all patients are to avoid the culprit medications, smoking cessation, and use of loperamide, SOS, or HS basis for the nocturnal symptoms only. If the disease is active, that is more than 3 stools per day, then one can add budesonide for 6 to 8 months, 8 weeks, and if there is subclinical response, one can give to 12 weeks period. If it doesn't help, add-on therapies include cholestyramine, bismuth subsalicylate. Excluding other etiologies, biologic agents and immunomodulators have been tried, and very rare surgeries. Point I want to stress is therapies which lack efficacy is aminosalicylates. These are of no use in such patients. In fact, lactobacillus, acidophilus, and bifidobacterium also are of no use, as in the case of octreotide. So I would like to summarize. Microscopic colitis is chronic intermittent diarrhea, which requires a very high index of suspicion from the clinician's point of view. A female with age around 65 are the likely candidates. Lymphocytic colitis have a favorable prognosis over the long term than collagenous. Antidiarrheals alone are good enough for mild diarrhea, and budesonide is the drug for active microscopic colitis. Thank you.
So very interesting and rare cases, Ravi. What is the duration of illness in both the patients?
Around 2 months.
2 weeks. So
2 months.
my question is that most of these patients have chronic course, like indolent diarrhea persisting for weeks or months, and after that we come to this type of diagnosis because very rare condition. So is it possible that in infective conditions we can get similar histopathological findings because we don't do chronic biopsies in normal mucosa so often? Is it possible to get such histopathological findings in such patients, in patients who are having acute infective colitis?
So these patients fitted into the chronic diarrhea, and we ruled out. I have not mentioned many things. We did a chest X-ray. We ruled out the other etiologies, like we did IgA, TTG, and all in these cases. And we actually, sir has always told us we have to take biopsies in the normal mucosa as well. In fact, even in the IBD cases. So we pick up in such cases when the colon is normal, and we were suspecting them to have either IBS or have some IBD-like features because of the long-standing symptoms.
since these patients have a higher tendency of recurrence of diarrhea, so is it like it is required to put them on some maintenance therapy?
So if we induce by 9 mg of budesonide for 6 to 8 weeks, we can taper to 6 mg for next 2 weeks and 3 mg for another 2 weeks and then stop. We can evaluate them after stopping the therapy whether they have a relapse or not. And for there is no specific maintenance therapy. It is symptomatic with loperamide if it is not bothersome.
So both the patient didn't require steroids, right?
No, none of the patients requires.
Question from house.
One, both each of the Ravis. So, okay. The lymphocytic infiltration in collagenous colitis and versus lymphocytic colitis, is the quantum can be similar? Or in other words, can a patient fulfill the complete requirement for both collagenous and lymphocytic in the same biopsy?
Actually, by definition, no. The reason is if you start getting collagenous band more than 10 microns, then even if you see lymphocytes, usually to make a diagnosis of collagenous colitis, the lymphocyte in the epithelial cell should be less than 20. If it is more than 20, then it qualifies lymphocytic colitis. So collagenous band usually such overlaps are, as far as I am sure, it's not known. And secondly, in such cases when there is a doubt, the CD3 staining will come to your rescue because it's a T cell mediated immunity. So you do a CD3 cell. If the CD3 lymphocytes are positive, then it essentially becomes a lymphocytic colitis. And I think both the conditions have no malignant predisposition. They don't become adenocarcinomas or malignancy at a later date. And most of them are self-limiting, I think so.
I would just
One
like
question for you. So, is it classically a large volume diarrhea or a small volume diarrhea? This microscopic colitis.
Usually
Because
it
in
is a-
first patient it was large volume diarrhea, and second it was small volume
Yeah,
diarrhea.
usually it should be small volume as it is involves the large bowel. But we can have watery diarrhea. It is difficult to quantify and classify as well. So one patient had large volume, one had small, but usually it should be small if we go by the pathological involvement of the colon.
Small or large? Large word.
So I guess because it's a secretory,
It has
some
secretory
component of
components to it,
secretory.
yes.
That's why the volume can be large at times.
Probably.
If you go and dig into the mechanism, probably you might get overlap there.
Probably.
Saurabh.
Yeah, I just wanted to make. Yeah.
Association with autoimmune diseases.
Yeah,
You can, I mean, especially lymphocytic colitis.
Yes.
You can get in Hashimoto's, you can get in thyroiditis. I mean, like you also suggested, you did a TSH and all that.
Exactly.
But then, like he asked me why it is not infective. Crypt changes, which are very important. And by and large, crypts look normal. I mean, like in this, I mean, I would have passed it off the first one as normal. But suddenly I started seeing that band, and this here I was lucky. That was very obviously more than 10 microns. Otherwise, this marginal 7-8 microns, I mean, I can never in my life diagnose an incomplete collagenous colitis. And most of them are self-limiting. The way patient have responded, probably I am right.
Yeah, so just a couple of comments. So in the West, where the biopsies are done very frequently, routinely, procedures are done. So we did end up seeing quite a few of these patients actually. It wasn't uncommon for us to see microscopic colitis. I mean, almost there could have been. One of my mentors was a microscopic colitis expert. So he had literally a clinic of microscopic colitis. So by and large, if you look at association, it's SSRIs and PPIs, and practically every second patient is using them. So it is hard to clinically diagnose these patients because, association PPI, like every second patient in India is having PPI. So you cannot really find that clinical association. Now, in terms of treatment, yes, budesonide is I would put it as a second line oftentimes. You correctly manage that with symptomatic treatments. But what sometimes works quite well is actually bismuth subsalicylate. So it's can actually make some changes in the stool in terms of color and makes it dark, but it actually is quite effective. And that's something that we actually use before we, use budesonide, just because it works, it's safe, So thank you.
We have
Just one last comment. When one is freshly passed out from DM, this knowledge is so fresh, and for first 10 years of your practice, you do such biopsies right, left, and center. And when you don't get a single case for 10 years, that's when you kind of stop doing it. You ask Vaibhav, you ask others also. In initial days, actually, we used to do such biopsies in all patients with diarrhea and normal looking colon, but then you get disappointed. But I guess it's worth now restarting that practice. Thank you.
So we have four questions from online participants also. We have three questions from Abhiram sir. One, that is whether this diarrhea was clinically small bowel diarrhea, which Prashant sir also asked. Second, any drug history or complementary or alternative medicine history intake was there?
No, no.
It was not there.
We ruled out.
So how does histopathology differs from SRUS? Question, I think Ravi sir can ask this question.
SRUS will, I think, clinically look different. Actually.
Right. So it is a classical histopathological findings, so which can differentiate this from SRUS. Dr. Abhijit is asking whether can normal IEL be different in tropical countries? Normal IEL level cutoff, should it be different because we have more often infective diarrheas? So should the cutoff be a little higher in our country?
I think you start sending more cases, we will have our own statistics. I don't know. I'm not sure.
So we have our online chairpersons also, Dr. Pankaj, Dr. Rajesh, and Dr. Shivaji. They can ask questions if they have some comments or questions. They can unmute and ask the questions. So if not, I would like to share my experience. I've seen just one case in the last 10, 12 years. There was a young lady who had persistent diarrhea for 2 years. And again, nothing was left. So I did biopsy. It came out to be microscopic colitis. So I gave her 5-ASA and she responded very well. She was under my follow for around 4 years. She was really well with 5-ASA. And as soon as she used to stop this drug, she used to have recurrence. So this is the only patient I have seen in my practice. So anybody would like to share their experience with macroscopic colitis?
Not useful. And according to the
At
studies,
that time, bismuth was not available, so I had no option but to give 5-ASA, and she really did well with that 5-ASA.
actually there was one trial comparing 5-ASA and placebo. Placebo response rate was 49% and 5-ASA was 62%, which was not statistically significant.
So questions? Any more questions? So if not, then thank you, Ravi. We can move on to
Thank
our
you.
next
Thank you.
case. That is large bleeding cecal polyp in patient with recent CABG. Achha, one more. Sorry. Sorry.
I take this opportunity to welcome the new persons, Dr. Rajesh Singhania, Dr. Pratik Padole, and Dr. B.A. Padole, senior surgeon. They have already been introduced. Before I go to the case proper, I have few comments. One, as Prashant has said, we also in between, after the first decade after PGI, started taking biopsies from a normal colon. Subsequently, it went off. But I think whatever protocols are there, they should be followed because otherwise you won't be able to pick up these cases and you would not say that this is not common with us or we will not be able to pick up these cases. As far as Dr. Amit's question was there, any patient with 2 months history of diarrhea, less likely to be some infection. Normally, we expect that 4 weeks, the acute infection should subside. I'll just tell you one interesting study which we did when I was in PGI Chandigarh in 80-81. We had that time rigid sigmoidoscopy and we did biopsies from a patient of neurology department, cardiology department, and studied the normal histopathological flora, and this paper has also been published. So the normal flora in Indian population also contains inflammatory cells because of recurrent infections. And so, we need to quantitate what is normal in our population and then say that this is abnormal. With this brief introduction, I'll proceed to the another rare patient. This was little complicated, a 67-year-old female who had come to us in July 21, suddenly there was crop of all these 2 or 3 cases together. So we thought that we should present this. Diabetic and hypertensive for 10 years, taking telmisartan, hydrochlorothiazide, and metformin. She had COVID in April 2021. Sometimes diarrhea and constipation with a frequency of 3 to 4 times. Mucus was present. The motions were small in quantity, no blood. She had a weight loss of 10 kg, significant weight loss. Recurrent urinary retention, no history of abdominal pain, NSAID, and fever, and received antibiotics outside. So, clinical examination, there was no joint pain, rash, and arthritis, no lymphadenopathy, vitals were normal. The per rectal examination and the per abdominal examination was not significant. She had an anemia of 9.7, low albumin. Stool examination was normal. Stool CDTA was negative. A1C suggested good control of diabetes. B12 was normal. We got her immunoglobulins, which were normal. Tissue TTG is negative. Ultrasound revealed fatty liver. So we had a patient who had diabetes for last 10 years, was on telmisartan, on metformin 500 milligram, had a COVID and significant weight loss. Clinically, the diarrhea was that of a large bowel type of diarrhea because there was mucus in small stools. So the differential diagnosis was colonic malignancy, could be diabetic diarrhea, drug-induced diarrhea, because metformin and telmisartan, normally we expect a metformin dose of 2 grams. Olmesartan is a very well-known cause of diarrhea, but we reviewing the literature, telmisartan is also one of the causes. And of course, now you have heard about microscopic colitis. That was there. SIBO, in all diarrheal patient, one has to also think of SIBO because of significant weight loss. Celiac disease is very common in diabetic patients. Pseudomembranous colitis because she has received multiple antibiotics. Whether it was COVID related, there are cases of segmental colitis reported after COVID, mostly secondary to ischemia, and there are cases of acute hemorrhagic colitis reported after COVID. So we got the endoscopy done. Just to show you, the endoscopy revealed that there was little flattening of the duodenal folds. As you can see here, not very classical, and there's a big duodenal diverticulum there up on the 12 o'clock position. We did a biopsies. The histopathology was not supporting the diagnosis of celiac disease. I'll ask Dr. Ravi to comment once the CT examination was done. We showed evidence of diverticula in the colon, in the sigmoid colon. As you can see here, the yellow arrow and 2 white spots, these are diverticuli. The colonoscopic examination is done. The preparation was very poor. However, we could see some findings, and these were in the form of ulcerations in the sigmoid colon. You can see a big ulcer there, quite a big ulcer. We tried to negotiate it beyond, and after negotiating beyond, what we could see that there was a narrowing in the sigmoid colon, so there was inability to negotiate the scope beyond with a small diverticular opening, which I not be able to show you here, and cobblestoning type of mucosa, pseudomembranous type of pseudo polyp like mucosa. So pseudopolyp-like mucosa, ulcerated lesion, narrowing of the colon. Now I'll request Ravi, what was his finding?
Actually, the colonoscopic biopsy showed all the features. Like there was some degree of cryptitis, like I have shown an arrow where there is some mild cryptitis with crypt branching, but otherwise it was showing submucosal inflammation. There was hemorrhage on the top, and there was no classical granuloma to call it Crohn's, or there was not many basal lymphoplasmacytic infiltration. In fact, after seeing this slide, we thought we'll call it some acute inflammatory process with ulceration, granulation tissue, and we did not feel like calling it, we called it practically benign mucosa with inflammation, and it was almost like an active colitis. We could not call it an inflammatory bowel disease, although there were some features where we were slightly doubtful whether we were dealing with an inflammatory bowel disease. But then ultimately we decided to call it acute colitis and stop there. Yeah. Yeah, more than 6. Yeah, but then acute and chronic. Yeah, acute and chronic. Yeah.
Except for this crypt,
Yeah,
which
other-
is below the hemorrhagic
Yeah,
spot,
yeah, yes.
there is no crypt branching.
There was no crypt branching, and there was no cryptitis, like to call it ulcerative colitis. So we called it. That is why we were not sure to call it an active colitis or chronic colitis. Of course, like he said, that by definition, yes, some degree of chronicity is there, but then to call it inflammatory bowel disease was not possible for me.
The TB PCR and the gene expert did not reveal anything abnormal. I must tell you that the rectum of this patient was normal, and it was the disease which was involving the sigmoid colon, narrowing of the sigmoid colon with diverticuli. So observed for 2 weeks, SOS colonic dilatation. We did not offer dilatation because there was an active disease. Patient was not willing for any treatment, put on laxative, metro, 5-ASA, observed for a couple of days and was doing well. Now we had, for the last 7 days, we have been trying to get in touch with the patient, and the phone is not answerable. So we failed to have the latest update on her. Ultimately, we kept a possibility that this is a segmental colitis associated with diverticulosis. There is an entity which is called as SCAD, segmental colitis associated with diverticulosis or diverticular associated colitis. That's which is well accepted entity. Inflammation of the colonic mucosa in the segment which is associated with diverticuli. Sigmoid and the left colon are involved. Rectum and the right colon are spared. Histologically, there is evidence of inflammation. It's rare. Diverticular disease is common, around 25% to 50% of the elderly population, depending on the age. 5% of diverticular disease can be SCAD, segmental colitis associated with diverticulosis. The range can be 1.5 to 11%. Apart from diverticulosis, the SCAD occurs in a younger age. The clinical presentation is very similar to that of IBD: abdominal pain, diarrhea, bleeding PR, even after histopathology, difficult to differentiate. There are 4 types of this. A is just crescentic fold inflammation. You can see this red inflammation, but rest of the mucosa is normal. B is like ulcerative colitis. C is like segmental colitis, Crohn's disease, and D is like severe ulcerative colitis. So severe form of ulcerative colitis. So these are the 4 types. Pathogenesis is described as ischemic, bacterial stasis and dysbiosis, and stasis of the fecal contents. The greatest challenge is to differentiate this from ulcerative colitis. The sigmoid and descending colon are commonly involved in diverticular associated colitis. These are the similarities. Endoscopic lesions are similar, as you have seen. Histology also may be similar. You have high interferon alpha in these patients and good response to mesalamine. What are the differences? IBD is in a younger age, and this SCAD, segmental colitis associated diverticulosis, is older age. Rectal involvement is common in ulcerative colitis, not in SCAD. Relapse rate is less in diverticular associated colitis, more in ulcerative colitis. Maintenance treatment is needed in ulcerative colitis, but not only in some patients with diverticular associated colitis. The treatment is antibiotic, ciprometrogil, 5-ASA, steroids usually in severe cases, beclomethasone, biologic surgery, rarely used. The final impression of our patient was either it is a diverticular related associated colitis, could be COVID related colitis. We did not do the D dimer and the other things of these patients, procoagulant workup. But the interval after COVID was after a gap of 4 months. April, she had COVID and started her symptoms. So, COVID is known to be associated with segmental colitis, and the mechanisms are three. One, direct virus involving the mucosa. Secondly, inflammation. And third is vascular ischemic insult. And of course, Crohn's is also one of the differential diagnoses when you have patient with segmental colitis. But then, as Ravi has suggested, that histopathology has not shown any future suggestive of Crohn's disease. Thank you.
Very interesting case, sir. Sir, this patient had diarrhea since last 10 years.
Not 10 years.
What is the duration?
Diabetes had 10 years.
Achha, diarrhea.
Diarrhea was recent on, means 2 months or 3 months.
Right. The question and
Diabetic
comments.
was 10 years. Sorry.
Excuse me, sir. Sir, indeed a very interesting case to be discussed. Sir, although the pathogenesis in a diverticular associated segmental colitis, ischemia is involved, do we consider purely ischemic colitis as a differential, given that she's an aged lady with all the comorbidities?
Yeah.
And did we do a imaging, cross-sectional imaging for it?
Yeah. We did CT with that idea only, that whether we would get some ischemic changes, number one. Number two, ischemic colitis by and large should be associated with severe abdominal pain. This patient did not have abdominal pain. So clinically, I would not say that this is a ischemic colitis. But I agree with you that ischemic colitis, when there is a segmental colitis involving a particular segment, especially in the sigmoid colon, one should always think of ischemia as one of the differential diagnoses.
Thank you, sir.
The histopathology, ischemic colitis would be different. Huh? You can take the mic.
The ischemic colitis usually will be slightly different. Especially in this case, it never looked like ischemic colitis. Ischemic colitis once in a while can look like Crohn's disease, but the pathology starts from mucosa. You can start seeing atrophic mucosa and then a chronicity in the form of fibrosis and some inflammation, and you can see prominent vessels also, which is not that difficult to distinguish. But then, like he had shown a slide where practically inflammatory bowel disease will look like diverticular associated colitis. So it has to be a clinical diagnosis. I am going to call it, like he very correctly pointed, I should have called it acute on chronic colitis and stopped there. But then there was no way I could call it Crohn's because there was no evidence of Crohn's, and it never looked like ulcerative colitis, and rectum was free.
The only unfortunate part was that because of the stricture, we could not see the proximal colon. But radiologically, the right side of the colon, the thickness and all look normal, but we can't be sure.
So on endoscopy, sir, the differential is between Crohn's and tuberculosis. When you see such kind of picture on endoscopy, diverticular disease as such is also
Yeah.
common. But
Yeah, I
what
agree.
is uncommon is diverticulum with
But
segmental
sigmoid
colitis.
colon tuberculosis, is not very common. I would.
So segmental tuberculosis can affect any part of
Yeah,
the colon.
yeah, I agree.
But I would like to ask Dr. Ravi, can you conclusively exclude both TB and Crohn's on this biopsy?
TB to some extent, yes. Crohn's, like you said, I mean, any acute and chronic colitis, Crohn's essentially is a differential diagnosis. So it cannot be excluded. But then it did not show any granuloma. It did not show any edema of the
See, basically, sometimes it is extremely difficult, and the follow up is very important before. There are cases of diverticular associated colitis. When they were followed up, they landed up in Crohn's or some other disease. So, what I mean is, at one point of time, but the my idea of presentation is that once you have diverticuli surrounding and inflammation, the take home message is one should always think of this entity that this may not be ulcerative colitis, Crohn's colitis. This may be an entity which is totally not that malignant or not that bad prognostic as Crohn's and other IBD.
We have a lot of questions from our online attendees. One from an anonymous attendee: can the biopsy miss macroscopic colitis? And what is the ideal biopsy technique? It was for the first case. So I think we can-
Microscopic colitis has already been discussed.
Right, right.
And the ideal biopsy technique, there was a lecture which I was chairing for a half an hour in ISG. So there are so many. In fact, I felt that I should send the technicians, our endoscopy technicians, to the pathologist to see what is ideal, including the number, the orientation, how to mount the biopsy. I was chairing that session. So, there are so many things. What is ideal, right from taking biopsy, mounting, and staining and cutting.
It is said that most often the disease is predominantly proximal colonic involvement is there. So one should always take biopsies from the proximal colon. So we have a question for Abhiram sir also. Is it possible to have protein losing enteropathy? So we have diagnosis very clear here. There is large bowel type of diarrhea. Another question, that there has been increased incidence of various malignancies after second COVID wave. So there must be some correlation with COVID and precipitation of malignant potential of these diseases. We have one Dr. Ali Adami. What is the cause of her low albumin? And do you think she has protein losing? Again, same question, probably because of malnutrition. And few more questions. Is it prolonged COVID, or should we do antibodies IgG for COVID? So I think it seems a little different from COVID infection. Again, if no more.
Yeah, protein losing enteropathy might be there, but basically it involves predominantly small bowel than the large bowel. So we will not be able to answer that question unless until you do the radiolabel studies to find out whether this stool contains more loss of radiolabel material.
So if no more question from our online chairperson or offline, then we can move on to the second case.
Thank you.
Thank you, sir.
Thank you.
So we have second case to be presented by Dr. Atul Gawande. The case is of large bleeding cecal polyp in patient with recent CABG.
Good evening, everyone. Today we are going to discuss a large bleeding cecal polyp in a patient with cardiac disease. A 70-year-old female with a recent history of CEBG with recent mitral valve replacement in November 2021. She was on dual antiplatelets and warfarin. She presented with the history of bleeding PR since 10 days. So the colonoscopy was done. We showed a large polyp of size approximately 4 to 5 centimeter, along with some clots and bleeding spots. The multiple biopsies were taken from the polyp, and the rest of the colon was normal. So this is the histopathology slide. May I request Ravi sir to elaborate
This
finding?
almost looked like adenocarcinoma, but then it was villus adenomatous polyp with high-grade dysplasia. By definition, unless you see muscle infiltration, I am not going to call it adenocarcinoma. So I called it that this is a villus adenomatous lesion with high-grade dysplasia. Invasion status, I am not sure, but the brisk mitosis and everything was so obvious that I gave a suspicion of adenocarcinoma. But then infiltration part, I could not comment because the biopsy was superficial. Yeah.
So as the biopsy was superficial, so and there was a risk of adenocarcinoma because of the age of the patient. So we can skip this slide. So the CT was done, and in a CT, so here we can see. So this is a cecal polyp, which is involving almost a whole lumen, and it was arising from the medial wall of the cecum, and there is no local infiltration or lymph nodes, and the other findings in CT abdomen as well as CT chest were absolutely normal. Because of the age of the patient and the recent history of CBG and with the mitral valve replacement, so we decided to do a polypectomy in this patient rather than the surgery. So the ESD was done by Dr. Saurabh. So I would like to.
Sorry, I think, let me just go here. Increase the size. Okay. Let's see. Hi, sorry, good evening, everyone. So, yeah, just by the way, onco surgeon had already seen this patient and felt and actually wanted us to consider a non-surgical approach if it can be tried. Rahul? Sorry for the technical issues here. Yeah? Okay. Right. So, now oncosurgeon had already seen this patient and was concerned about the age, the comorbidities. The patient was on Plavix, as in clopidogrel, and they wanted us to see if we can do an endoscopic resection. Possibly, I was a little skeptical since there was a concern for high-grade dysplasia with villus adenoma. It's almost suspicious for malignancy. Whether we will be able to do justice by doing an endoscopic resection. So anyway, we took this patient for colonoscopy, and now what you see is we are looking at the cecum, and the polyp is arising, the polypoid mass rather is arising from the medial wall. And initially, given the large size and what we felt was a stalk, so therefore we decided to attempt placement of an endo loop. Now, what you see is the lesion is so big that it was just practically not possible to effectively place a loop across and do this successfully. So, so while the plan was initially to do endo loop, I then decided to perform endoscopic submucosal dissection in the cecum. Colon can be a challenge, and especially cecum, because your scope is obviously looped in, and it can be a bit of a challenge as the scope keeps falling back. So what we do is we mark, in this particular case, as best as I could see, the margins of the lesion, the stalk. I injected some glycerol with methylene blue, and then we start with our ESD knife. We start dissecting into the submucosal space. And as we dissect, and what you can see is right side of the colon has a thinner wall and there's certainly vascularity. So sometimes you encounter vessels which can be prophylactically coagulated with coagulation grasp or forceps. And then we continued our endoscopic submucosal dissection. And now, as you see, as I'm performing, now what you ideally want to do by now is to create some degree of triangulation where you pull the two pieces apart, and then you should be able to get better visualization of the submucosal space. And however, I was able to manage without it, without putting clips and doing this. So I decided to just continue. And now as we are continuing here, right? So typically we prefer straight scope positions for doing dissections, and in my opinion, I would say colonic ESD probably, in my opinion, is as tough as ESD in the duodenum, or probably tougher. And I would say this is probably the most toughest ESDs that you have to do, because you're really having a lot of bends and loops in the scope. So the scope stability is the main problem. Now here, we had constant issues with bleeding, and finally, after what you see is active bleeding from the submucosal space. And then I may just move it forward a little bit. Yeah. Although there was some degree of bleeding, I'm using something called an insulated tip knife, which we use in POEM for cutting the muscle here. And again, this was getting annoyingly difficult with the bleeding vessel. So I anyways decided to just go ahead and cut it out. So now I've really managed to get it out on block. And then, so this can now become challenging because there's constant bleeding from the submucosal vessels. And in this particular case, of course, not shown in the video, the scope kept falling out. We kept having to go back and forth, back and forth. It seems a lot easier as we have edited it, of course. But then what happens is when it goes out, then it bleeds and you can't see the surface well. But somehow we eventually managed to get it done, and then get this entire mass gradually out. So I think that's about it almost. So in process, it was fragmented in pieces, but either way, we managed to get the entire thing out. Yeah. Atul, I suppose Atul can take from here. That should be apps. Go ahead.
So this is the polyp size. The size is approximately 4 centimeter along with the stalk. On histopathology, again, Gavi sir, over to you.
In histology was very evident for us that there were areas of villous adenomatous lesion with high-grade dysplasia. There are almost adenocarcinoma-like areas. Can you show my report as well? There was brisk mitosis.
We don't have the report.
And then we painted the whole specimen, because that is what is like how to process the sample. Like sir was telling that he will send a technician. We painted it to see whether the base and the margins are free, and they were absolutely free. So it was a beautiful resection with all margins clear. So we reported it as, and there was some degree of infiltration in the muscularis, but then muscular mucosa, but then the stalk and the base were absolutely free.
Thank you, sir. We had a telephonic conversation with the patient just 2 days back, and she's doing well. There is no delayed bleeding. So this is the just two slides of this presentation. Just having the So this chart was taken from the ESG guidelines for the management of the superficial colorectal neoplasia. So it depends upon with the type of the polyp, whether it is sessile or flat or pedunculated. So if the head size in the pedunculate polyp, if the head size is less than 20 mm and the stalk width is less than 10 mm, so the hot snare polypectomy can be used in this patient. And if the head size is more than 20 mm and or the stalk width is more than 10 mm, the injection with 1 to 10,000 adrenaline with or without a prophylactic mechanical hemostasis can be done and followed by the hot snare polypectomy. So in our patient, as we could not put the endo loop in this patient, so we decided to do ESD in this patient. Now coming to the sessile or the flat polyp, if the size of the polyp is less than 10 mm, so a cold snare polypectomy can be done, and if the size is more than 10 mm, the patient should undergo advanced endoscopic imaging or at least a high definition endoscopy to evaluate whether it is the non-invasive lesion or whether it has the superficial submucosal invasion. So in non-invasive lesion, if the size of the polyp is less than 20 mm, the hot snare polypectomy can be done. And if the size is more than 20 mm, the EMR can be done to achieve RO resection. And if on the high definition endoscopy or advanced endoscopic imaging, if there is suspicious lesion of if it is suspected that the tumor has only superficial submucosal invasion, then the ESD can be done in this patient. And if there is a deep submucosal invasion, then the only option is surgery. So now there are so when will you consider that the polypectomy is curative? So there are certain criteria. The most important is the RO resection. Second is it should be a well differentiated adenocarcinoma, and in a patient with the superficial flat or elevated polyp, if the invasion of the tumor is less than 1 mm in the submucosa, or in case of pedunculated polyp, if the level is the Hajet level less than 4, or absence of lymphovascular invasion. So in our case, the patient has all the criteria. So in our patient, the patient has had a pedunculated polyp, and as sir says that the lesion has invaded into the stalk, but not into the colonic wall. So it was less than Hajet level 4. And coming to the surveillance after curative endoscopic resection, the surveillance endoscopy should be done after 6 months after index treatment, and if it is normal, then it can be done yearly thereafter. Thank you.
Thank you.
How did you manage the pre-op anticoagulation?
Yes, sir. So patient was on dual antiplatelet, ecosprin as well as clopidogrel. So we stopped clopidogrel, and aspirin was continued, and we stopped warfarin 5 days before the procedure. And after that, we put patient on low molecular heparin 2 days after stopping the warfarin, and which was continued till 24 hours before the procedure. And we started the warfarin as well as the second antiplatelet the next morning after the procedure.
Sir, excellent dissection.
Thank you.
I just want to ask, can you do a standard polypectomy or EMR in this situation?
No, I think good question. So I think the problem in this particular case was that we could not even see the polyp properly. It was so big that basically barely I could see the stalk on one side. The other side was totally not visible. We pulled it apart, pulled it outside, we pulled it out. You would still not be able to do it. So if you can't put a huge loop around it, so I suppose with a huge stalk, it was not possible to do any regular EMR technique. That's why we had to do ESD. Was the only possible option in this particular case. Piecemeal, again, you would again cut through the polyp, then the polypoidal mass, and then you would do some part of the stalk. So now it's a huge pedunculated, large stalk polypoidal mass. So it's not just, we can do like 5 and 10 centimeter EMRs if they are flat. That's much easier. This, because we just can't see, it's especially in the medial wall of cecum where I couldn't see much.
Do you think the stock made it more safe to do a ESD, or the risk was?
I would say that I don't know about safety per se, but the more you dissect, the more risk is there. If you can imagine, if there's a 5 centimeter polyp which is flat, there would be higher risk as I have to dissect through more tissue. So that way, yes, compared to a flat lesion, it was safer. But yeah, I mean, if that's the comparison you're saying. Yeah.
What would have been the stock size here? And
the stock size would have been at least 2 to 3 centimeters. So it was not like a small stalk. It was a big, wide stalk, thick stalk. I'm afraid I can't show you exactly the pictures because obviously,
you would have gone midway through the stalk in the dissection or flush with the colonic wall?
I'm sorry. If
you would have gone in your dissection flush with the colonic wall or through the thickness of the stalk in the dissection?
Yes. So we have to go through the entire thickness of the stalk, through the submucosa, lift, separate it through the entire submucosal space
you
of
are
the
in
stalk.
a way away from the
Muscle area.
colonic wall. That's why I am saying that the safety would have been slightly more had it been a
flatter lesion.
Because very thin.
Correct. It was a big stalk, and therefore we had room to play around with.
Yeah, good improvisation.
Thank you.
Saurabh, excellent presentation here. My question is that if you have been successful in applying endoloop at the base of the polyps, would have gone through the resection in the same sitting or would have waited? Because most of the time what happens if you apply endoloop, when we resect the polyp, the endoloop also get cut off because there is no margin in such patients when the polyp is especially sessile. What I practice is that I leave the polyp like that, go again after a few days when the polyp is small in size and then resect. What is your what do you do in such cases?
I think the first thing is, of course, the endoloop can be applied, certainly a reasonable option because it's easier and faster. It strangulates the base, so the vascular supply is gone, it becomes blue. Now, well, if you can get a snare across, I think it's better because then you can get histopathological specimen for analysis. Certainly, lymphovascular invasion, etc., can be determined. We prefer to have a snare above the endoloop if we can and cut it. That would be our preference because endoloop is ultimately serving the purpose of preventing bleeding. I suppose you can go back, but I don't know until how many days it's going to survive. Maybe it'll just die off and fall out and we don't get histopathology specimen. That would be my concern in this case. So ideally, if we can get specimen would be preferential. Yeah.
Excellent presentation. We have few.
How much time it had taken to resect that specimen?
I think I had two barriers. One was there was one instance of bleeding which really, and then the scope kept falling back. That was the other problem. So during, it would have been like 45 minutes normally, but then with the bleeding and the scope falling out, it took me about 2 hours. So in this particular case, I would have guesstimated 45 minutes to an hour, should have done it, basically.
It must have been done under GA.
No, she was in conscious sedation.
Okay.
No.
You used a colonoscope, I guess.
Yeah. We used a colonoscope. Actually, this was a shorter scope that we had. I have to see which one is it. But it had narrowband imaging and stuff.
We have a lot of questions from our online participants. A lot of questions from Dr. Manoj Vevare. What was the serum CE level of this patient? CEA?
I'll have to see if it was done. No.
So earlier report was showing signaturing cells. So was it aggressive mass or polyp? So was there no signaturing cells? Okay. Well differentiated. So how much was the stock size on final specimen? 2.5 to 3 mm.
Centimeters.
Centimeters.
2.5 to 3 centimeters.
Can EMR be easier as compared to ESD here?
Yeah, I think we just discussed it.
Yes.
It was not practically possible to do EMR.
Okay. So Dr. Vaibhav is asking why not consider piecemeal resection in this case?
Yeah, it's just not possible.
There is one question by Dr. Mashiko Sete. Well done on your management. Would a laparoscopic resection be so risky or more safer in such cases like that?
Yeah, no, that is an onco surgeon who had evaluated this patient and felt that if there's an endoscopic option, so they wanted us to do it. So we said, sir, yeah. I think comorbidities was the question.
Therefore, I asked the question whether it was given a GA.
Yeah,
With
no.
2 hours of endoscopy GA, a limited resection would have been possible.
Right.
That
right.
was the my
Yes, no, thank you. Yes. yes.
yeah.
And this patient had a mitral valve replacement a month prior. Even for colonoscopy, there was a discussion amongst the relations that whether she should be offered that procedure, you know. So they were very skeptical about getting. In fact, I told them to have a repeat endoscopy now, colonoscopy, to judge what is the polyp status. A basic referring physician said that wait for 3 months and then let it go. And she was also out of station. So both these factors, you know.
Thank you, Atul.
But I must say that that was a cure to the patient. That's, I mean, as of now, what we can see.
Very excellent, excellent presentation. Thank you, Atul. Move on to the third case, that is fistula closure by over the scope clip. To be presented by Dr. Bhushan Bhaure.
नाही आता सांगेल तेच कुठला आहे विस्टूला माहिती नाही कारण की नंतर एंटरोक्युटेनियस विस्टूला पण आहे नंतर
Yes, good evening everyone. So today's my case I'm going is a fistula closure by a routine OTSC, but it is what we call as a wire assisted over the scope device. Yes. Yeah. So he's a 46-year-old male who was diagnosed who has a right colonic adenocarcinoma, for which patient has underwent outside 3 cycles of neoadjuvant chemotherapy, followed by an exploratory laparotomy and right hemicolectomy in May 2020 elsewhere. As per the patient, he has some little turbulent post-op course. He has developed some abdominal collection for that, and which was managed over time in the ward course and was subsequently discharged. And post-surgery also, patient has underwent 3 cycles of post-adjuvant chemoradiotherapy. So he came to Midas with a complaining that he has had a swelling of his shirt with a feculent material from his abdominal wall since last 6 months. The last cycle of chemotherapy has reduced chemoradiotherapy as 6 months back. During the course of chemoradiotherapy, also the patient has a continuous feculent discharge, and which over a days has so much increased that he has swelling of his cloth and feculent discharge. And on perabdominal examination, he has attached a colostomic bag, and it was draining around 100 ml per day. It contains a semi-liquid, it has a feculent material. Discharge from umbilicus. So on examination, it comes to be like that. He's have like a very enterocutaneous fistula. So he was not a septic at presentation. He was doing well. He came in standing, like he comes walking in the OPD. This was like we can see abdomen, like so small umbilicus. We can see a discharge also around there. So blood tests were within normal limit. Carcinoembryonic antigen was 1.5, and ultrasound showed is no abdominal collection. So we did a CT scan. And CT scan, there is no liver mets. We can see the but we can see a colonic, we can see a leakage of contrast into abdominal wall from a colon, mostly from a transverse colon as per our radiologist. So, sorry. So we did a colonoscopy just to see like where is the fistula. What we are seeing is from right colon. So the preparation not so well. So we see, and this was an anastomotic site, what you can see. And I enter into an neoterminal ileum, which was corrected, and was very carefully looking for any fistula. So there was no fistula seen in neoterminal ileum. So again, I went to the baseline anastomotic site, and I went into this blind loop, as there is some ulceration also seen there. And from the blind loop, then there was something from abdomen. I injected some methylene blue. And we can see yes, the fistula is coming. That there is a leakage from abdominal wall, and that is a fistula what we located. And then we corrected it's a colocutaneous fistula rather than enterocutaneous. And we also tried to pass a guide wire through that fistula to exactly locate what is exactly side from where we have to do, where it's coming. From abdominal side, yeah, from the percutaneous side, yeah. Dr. Bunk sir has helped in that. Like we can just locate it that where from we can pass a guide wire and just see. So this was a chronically non-infected, low output colocutaneous fistula. The etiology mostly a post-operative or maybe because of secondary to radiation. What we got, and there are patient is not having any sepsis, so it is a and have a very proper nutrition also. So we thought an option, it is an endoscopic option, mostly OTSC. We can apply some glue injection, and maybe a surgical option. And patient opted definitely for endoscopic option. So endoscopy operation, we given an over the scopic. It's a padlock script from Steris. It consists, as all we know, it consists of 11 ml nitinol ring and a trigger wire, and it is how it is mounted over the scope. And it comes in two sizes: a standard device and also an comes in as a Pro Select device. And we selected a padlock clip with a Pro Select with a Pro closure device. So we went with this loop, padlock clip into that same lumen, and we again confirm are we in the same blind loop. And from abdominal wall, yes, we again inserted same thing as you see, and we were able to see an end face. Can we get an end face? So this wire was helping us to exactly guide where it is. It was very difficult to get into exactly 360 degree, but somehow, as you can see, we can able to grab it where the point was able to see end face into us. And yes, we start sucking it, and we deploy. And with the trigger handle by assistant, we just deployed the clip here. Yeah. And slowly the wire was been pulled out. So here you can see this. Yeah. The clip was properly deployed. Subsequent, yeah. Post-procedure, patient had no complication. Drain output has reduced, and it was patient was subsequently discharged on day 2. On just date before yesterday, we had a follow-up. He's doing well and absolutely no discharge. A month back, he also came to our OPD. There was no fecal discharge, but there was some colonic secretion which was coming out. But now, day before yesterday, we just called. He has no discharge from his umbilicus. So yes, just a review of an literature. We had the clinical efficacy of over-the-scope device was studied in systematic review. This is a recent 2020 review from China, where almost 3020 patients was evaluated for management by OTSC clips. And as you can see, there was various indications from fistula, bleeding, and overall having a clinical success rate was around 90%, but fistula was on the lower side, managing around 50 to around less than 50%, with a technical success rate around more than 95%, and post over the scope leak surgical rate was less than 4%, and the adverse event was also less than 2% as per this clinical review. So as per a Midas experience of OTSC, we had a still last in 2020 to currently we have 15 patients who underwent an OTSC clip. The indications like FTRD, like out of 6 FTRD, GI perforation of 5, and GI fistulas were 4. Most of the patient, there were equal proportion of male and female patient. The mean age was around 52 year, and the technical success was 100%, and the clinical success was around 14 patients out of 15, and the adverse event was only 1 out of 14, where the clip got dislodged after 2 days after FTR upon duodenal NAT. It is a full thickness resection device, sir. Yeah, full thickness, yes, sir. Yeah, yes, sir. So the take-home message is that OTSC are safe, simple, and definitely for rapid deployment. It causes a paradigm shift in how we manage the variety of endoscopic challenges today. It is an effective tool to seal GI defects, achieve hemostasis in refractory GI bleed, and for EFTR for subepithelial and epithelial lesion, and definitely has a potential to spare a surgery and also the surgeon at that moment. Yes, sir. Thank you. Yes.
Nice presentation, Bhushan.
Yes, sir.
My question is there any difference in the outcome when do you OTSC application in esophageal lesion versus other places like stomach, duodenum, or colon?
Sir, as such, the systematic review, the lesions are mostly a esophageal stomach, but I can't find a very selective thing like esophageal perforations has a low success rate as compared to other stomach and other small bowel intestine. I wonder that I not found this thing. Even I reviewed this thing. Maybe Saurabh sir has.
Saurabh can answer this.
So I think more than the location of the lesion, I think it's the leak versus the fistula. is the chronicity which matters in terms of the outcomes. So I think it's on, right? Yeah. So I think if it's a fresh leak, the earlier you treat, the better it is. If it's within 5 minutes, great outcomes, versus after 6 weeks, inferior outcomes.
So just a follow-up question on this. What could have been the potential contraindications to an endoscopic OTSC clip if this fistula could have been, like if it was fibrosed or purulent, what could have been the potential contraindications?
Potential contraindications
Yeah.
for not putting an OTSC clip.
Yeah.
You are saying that are we doing some alternative management? Like what would have been done?
What could have been the potential contraindications that we could not, in this case, it was excellently done. Yeah, it was excellently
patient
done.
is a sepsis right now.
So the
This patient would have been
if there is any collection nearby that fistula which is undrained, so that could have, that is one of the contraindication to do any active management to close that and all. Until unless you drain the sepsis surrounding the fistula, you are not going to get the healing.
Second is the size of the lesion. If the size of the defect is too
fibrosis
much,
doesn't
then
matter.
It's one of the contraindication, definitely.
And I think Bhushan very nicely showed the video. I think few things to note. These clips are very bulky and big. So, and then they extend about 1 or 2 centimeters beyond the tip of the scope. So, while as easy as it looks on a video, putting it inside is not the easiest thing sometimes, number one. And number two, as far as contraindications are concerned, as Dr. Agrawal said, large size of the lesion, scarred fibrous lesion, and that can be a contraindication. This patient, honestly, Yogesh, me, we were all, and Bhushan, we were all there, and he was like, can you put a clip? We said, yeah, sure, but when I looked at it, it was in transverse colon, 90 degree up, then again 90 degree on the other side. So I said, boss, ये सब ठीक है, लेकिन पहुंचेगा नहीं वहाँ पे. So we reached in that little pocket there, and we were like, yes, but what am I clipping? Because you can put a clip somewhere, you don't know where it's coming from. And then we were like, well, this is definitely not on FOSS. And then we played around, we thought of a few ideas, and then we decided that let's just put a wire from outside and grab the wire from here. So then it becomes like straight in your face, you know exactly the hole where it is, and you put it. Because otherwise, we were literally ready to clip, and we were like, boss, this will not, it'll close some hole and some side, and then can cause failure. So the fact is, so it wasn't just about the guide wire showing us where it is. Because if you look at it, I'm going straight. The fistula, what she shows in the video, was on the complete 90 degree left. So if you want to get it exactly in the center of the screen, how will you get it? Because the scope is not going to turn after 4 bends. So that's what ultimately what happened. So the guide wire was grabbed, pulled inside the scope channel. Now the scope automatically had to look at the fistula opening, and then we had to place it. So that's the sort of uniqueness of placing the fistula.
Very, very innovative idea, sir. You only picked up that idea that we can get NFS, because I was doing like that. You were saying it.
Bhushan did it. That's the key. We were discussing, bouncing off ideas, what we should do.
Bhushan, just I asked you about the question about the esophageal purpose. So I would like to share my experience with esophagus. Out of my 4 patients, I observed dehiscence of the OTSC in 2 patients. After this happened, I definitely we don't have literature about the esophagus versus other organs. I had first-hand experience with a lot of people, and most of them agreed that because the esophagus is quite tight, it doesn't give any suction is less possible. It is stretchability is less, so the chance of dehiscence is extremely high, especially if the fistula size is more. So one need to be extremely cautious. You may be able to apply OTSC properly, but the chances of dehiscence of the clip is extremely high in patients when you do anything with esophagus. So one need to be very sure.
Recently,
OTSC. Dehiscence, because of necrosis, if you are not able to apply the OTSC properly, the dehiscence of the esophageal wall and the clip comes out. So you may be able to close that defect initially, but because of the dehiscence, because of necrosis, the clips comes out. So this is one observation I had.
But recently, OSCO has come with this stent fixation device for our esophageal stems, where OSCO, a small mini OSCO, has been applied for just for preventing a migration of fully covered stems. That one thing is applied where we can just push out the stent. Dehiscence is definitely a matter. Yeah.
I can only say that we had one dural perforation, which was being managed by putting an OTSC clip. And what was happening was the intubation of the patient was difficult. So ultimately, the idea came that we should put a over tube, and on the over tube, the scope was introduced on using the OTSC clip. Because sometimes what happens is, as we must have observed many times, that we do banding, and some patient putting a banding assembly, and when it goes inside, it's a difficult. The scope may go with banding assembly; it is difficult. So this is same sort of thing has happened because this is a bigger than a band which is applied. Diameter is more. Yeah.
So there is one comment from Dr. Abhijit Deshmukh that with active inflammation, the chance of descent is extremely high, and one need to be extremely cautious when there is active inflammation. Okay. So thank you, Bhushan. Now we can move on to our next case. If no more questions are there from the house, the case represented by Dr. Saurabh Mukkewar. This is cholangioscopy new indications.
Hi, good evening, everyone. Thank you. So, okay. So I would like to present a case in which we did a cholangioscopy, and just to highlight the usefulness of having it, which sometimes can be beneficial. So this is a 38-year-old female with history of diabetes, hypertension, hypothyroidism, presented at an outside institution with jaundice, pruritus, anorexia, undocumented weight loss, presence of icterus, and a CT abdomen performed outside showed suspicion for hilar block. An ERCP was attempted twice, but the details were not available at the time when we evaluated the patient. And the patient underwent percutaneous biliary drainage outside, and a bile for cytology was negative. But unfortunately for the patient, the PTBD got dislodged accidentally. And so she came to us for a second opinion, and she seemed to have fever with chills, vomiting, now had some jaundice. Bilirubin was up to 3.5, mild elevation of OTPT, and she was severely hyponatremic and hyperkalemic, and required treatment for the same. So we got an MRCP to see what was going on. Actually, this was even before she came to us. And what we see is a potential stricture in actually the mid CBD, in my opinion. And so the initial consideration was performing a US guided biliary drainage because the ERCP attempts had failed in the outside institution. So I said, all right, we can do a US biliary drainage in this particular case. And here I took this patient. And for those who don't do EUS, these are just black structures are the bile ducts. And this is the bile duct up in the screen. I can't point it, I suppose. Maybe I can use this. And yeah, so this is the gallbladder. And then on the other side, there was the bile duct, which suddenly was increasing in caliber proximally and consistent with the stricture. But my concern was the area where I'm going to puncture from was going to be in the distal part. So I said, well, let's give it a shot, because then if you go on this journey and put a cystotome and make a hole in the duodenum, you better be able to put a stent properly. So I said, all right, let's attempt the regular ERCP in this case once. So I took him for ERCP, and this patient has periampullary diverticulum, and we cannulated, which was not a problem. And as we are pushing the wire, what you see is the wire is not going, and I'm putting a lot of contrast. The contrast was not going, neither was the wire. We did a sphincterotomy. In fact, we also did a balloon occlusion cholangiogram. Right. So we did a balloon occlusion cholangiogram, which you'll see in a moment. Right. So I'm sitting right at the top proximal duct, and still, despite as much pressure as I could, neither the wire nor the contrast was going in the proximal ducts. So I said, let's give it a shot. And I put the cholangioscope up. And what you see is this mass which is completely occluding the bile duct. And there's fibrosis, as you see. There's some neovascularization and some papillary projections there. So overall findings were was concerning for malignancy. And so now we said, all right, like I was trying my best to find a hole where I can put the wire in, but as you see on the screen, there's really nothing that's visible. So then I got a guide wire. I said, nevertheless, I'm going to still try and poke it. And cholangioscope can be a little difficult to maneuver, and you can't, it keeps moving sometimes. So here we are trying our best. It's coiling back once, twice. And then eventually there was 1 micromillimeter hole in the middle, which wasn't clearly visible, but we could finally get the guide wire across. And now with the guide wire across, we had access to the proximal ducts. We did get some biopsies to, of course, get the confirmation. And then eventually the guide wire was in, and now we could do our routine ERCP. Now we now could manage to get a balloon across. Balloon dilation was performed of the stricture. And then eventually we decided to place a stent, which was a metal stent because this patient was in cholangitis, and worried that the plastic stent would either get blocked or be hard to get across. So the stent was placed successfully, what you can see, and there's a narrowing in the middle, which is reflective of this of the location of the stricture. Unfortunately for us, the sampling was negative, but good for her. Her jaundice got better, and LFTs improved, and basically then we decided to assess her whether she's surgically resectable. Given our concerns with cholangioscopic appearance for malignancy, we said, let's go ahead with a CT scan. And there was, fortunately for the patient, there was no loco-regional involvement with no lymph nodes or any mass, quite frankly, visible. So a definitive surgery was considered. And we asked Yogesh to, if Yogesh, you can comment on the surgery. I'll let you take over for the surgical part.
In MRCP, as we can see, there was a lot of duct proximally as well as distally. So we did a complete CBD excision for this patient, and hepaticojejunostomy was done. And I guess the final histopathology is showing malignancy.
Yes. Yeah. So the final histopathology did show T2 adenocarcinoma. So this patient did undergo a curative resection. And the patient now at follow-up after 8 months is stable with no evidence of recurrence, and with COVID issues hasn't been able to follow up, but hopefully she should be here soon. Now, just to sort of highlight the fact that one, cholangioscopic appearance is probably more beneficial than the biopsies, and oftentimes in diagnosis of malignancy, and which is what we felt and saw in this particular case. And the other thing is, we, I guess, to some extent got lucky in being able to get the guide wire across, but still reflects and shows, that this can be a useful tool in other cases. Now, we've done about 70 odd cholangioscopy, pancreatoscopy cases, maybe a couple of 2-3 patients that we've used this tool for guide wire access. So thank you. Happy to answer any questions here.
Thank you, Dr. Saurabh, sir. An excellent and atypical use of cholangioscope. Initially, I suspected that you would be saying कि वो PTBD tract में से you would put an cholangioscope.
No.
So nothing of that sort. A single age-old questions to all the surgeons in the house, and for my information and for the information of my colleagues. Surgeons at what level of bilirubin are comfortable for resection of an malignant obstructive jaundice? Answer in 2 points, the hilar types and the lower CBD types.
So for a hepatectomy, bilirubin less than 3, and for pancreaticoduodenectomy, bilirubin less than 15. That is what is my conventional teaching and what I am following. I have done it up to 22 in a case, in a single case. There was no complication, but I am comfortable if the bilirubin is less than 50.
Okay. So 15 is the general
Yeah,
cutoff.
yeah.
As you said, in hilar malignancy. So in hilar malignancies, majorly if the resection is required, then only we follow the bilirubin less than 3 ideally, and lesser the better, because we are doing liver resections there. And for bilirubin in non-liver resectional cases like in cholangio or maybe pupils, if the bilirubin, usually the level of the bilirubin is not the deciding factor. Moreover, if there is a coagulopathy or nutritional issues because of high bilirubin and associated cholangitis, because these are what we used to follow. At our institute where I got trained, we usually we have done Whipples at around 30 bilirubin also, where rest of things were good and patient's performance was better.
Yeah. Thank you.
See, I think also in this particular case, the diagnosis was not made, number
Yeah,
one.
yeah.
Wasn't clear, number one. And number two, she's 38. So, to clearly think of malignancy, you would have to sort of think twice before labeling that.
Sort of one doubt, I could not get it. You said you wanted to do a US guided procedure and then thought that you should again,
Try again,
give it a try with ERCP. What was the reason for not persisting with the US?
No, so the EUS was a failed ERCP, stricture in the CBD. Can we drain this bile duct? She's in cholangitis. So I took for EUS with the idea that it's failed twice. So EUS is warranted. The reason I didn't do it was because the access point where it was seemed lower on the CBD, which was a safer way to gain access, not on the proximal duct, which is where ideally you would want to get access. So I didn't want to attempt from the duodenum. The intrahepatic I could have tried. I think the question at that point was whether we do hepaticogastrostomy or we attempt a regular ERCP. So choledochoduodenostomy is low risk, relatively easier, straightforward. So we go for that first.
Procedure, no?
You're right.
Yeah,
So that's
but this is
it
the
so this way, yes, you're right. So there are a couple of reasons, right? Like the diagnosis was
All
not
for
clear.
good.
Number
All
one,
for
yeah.
good. We could not get a window. That was
Yeah,
for
good.
patient,
Actually,
yeah.
I honestly, it was not. I said, let's go to the US. Let's see what's going on. It wasn't like, yes, I'm going to do this patient this way. It was just more like a thing. Let's go in. Let's take a look. What do we see, and stuff. Basically, yeah. Okay. Great. No questions, Yogesh. You want to take over?
Thank you, Saurabh.
Thank you.
Excellent presentation. Now we move on to the last case, intercutaneous fistula. Dr. Yogesh Bang, please.
So my case is not having any video. It's not having. It's basically a clinical case scenario or the philosophy on which we work when we see a patient of intracutaneous fistula. And just for 10 to 15 minutes, you will have to bear with me. It's the last case, so just have a look what exactly we do. So a 25-year-old female, she had delivered on 23rd August 2019, and 1 month after her delivery, intrauterine device was placed, and immediately next day she had pain, distension, and the primary gynecologist or surgeon thought that there could be some perforation because of the pain and distension. So they explored it, the patient on 22nd September 2019. There is a laparotomy which is done. That's what the paper we got. And we don't have details of surgery which was done there. And after surgery on 11th post-operative day, on 3rd of August 2019, the patient was referred to Midas with pain, fever, and the enteric contents which are coming out through the wound. On examination, the pulse was 140, she was BP was maintained, respiratory rate was 32, she had fever of 99, but abdomen was soft and there was no tenderness. Even after having this much fecal output, and the wound looking like that, the abdomen was soft. On presentation, her hemoglobin was 6.5, creat of 1.8, and albumin was 2.4. So basically, post IUD perforation, post laparotomy, there is some leak and presented to us with that enteric content sepsis. She was anemic, hypoproteinemic, and acute renal failure was also there. So what's next? There are options like we go in, do re-exploration, assess what the leakage is, and tackle it, or snap. So this is what I want to stress in today's talk. What is this snap? It's not a snap which we do. It's something, a protocol which a patient with enterocutaneous fistula, we as a surgeon follow. So what this snap is, the surgeons who have read belly, they will very well understand this chart. So first and foremost, you have to eliminate the sepsis and give good skin protection to the patient. Look after nutrition of a patient. They may need a parenteral nutrition for a long period of time. Then assess anatomy of the fistula, what exactly is leaking, where it is leaking, and then plan a definitive surgery. So first, sepsis. These are the things which we start off to the patient. We keep the patient nil by mouth. Ryle's tube is inserted. Reasons for keeping a Ryle's tube is to decrease the fistula output. As the fistula output decreases, if there is some undrained collection, there will be no further increase in that undrained collection because something will come out through the Ryle's tube. Next, as the patient had acute renal failure, so we had to give good crystalloids, potassium and magnesium replacement. Patient was anemic, so PRC transfusions were given. She was put on antibiotics, piperacillin, tazobactam. Role of octreotide for enterocutaneous fistulas. They don't heal fistula per se, but the fistula output significantly decreases by giving octreotide. And we just want that in initial phases so that we avoid dehydration, so that we avoid the electrolyte imbalance to these patients. So the amount of feculent output or the amount of enteric output which comes out decreases significantly by giving octreotide, 100 microgram. And lastly, a CT abdomen we did as soon as the creat came down to see if there are any undrained collections. And good for the patient, there was no subhepatic or subdiaphragmatic collection here. There was a small undrained collection, as you can see here, which was aspirated through USG guided needle aspiration was done. And we could control that undrained collection and control the sepsis with this. So as we started with S, the next was skin protection. So earlier when I was resident, we used to apply silver paint on this, and we used to change the dressings every 3 to 4 hourly as the pads get soaked. That was very much difficult for patient to manage. Even the skin would get red and irritation would happen because of enteric content. Nowadays, we have these large bags. These are basically wound manager bags which collect all the enteric contents, and they drain out every fluid outside. The skin is totally well protected with these skin protection bags. So this is the part of S which we did for this patient. Next was to look after nutrition. Patient was kept nil by mouth, so we had to build her up. Albumin was low, so she was started on total parenteral nutrition with the requirement of around 25 to 30 gram per kg per day of calorie and 1.5 to 2 gram per kg protein. So within 3 to 4 days on 6th, she came to us on 3rd. On 6th, patient's pulse rate came down from 140 to 110 because of the resuscitation we gave. Fever was once a day, 99. Abdomen was soft and the respiratory rate came down from 30 to 20. Fistula output, in next 3 days, what we monitored was how much is the fistula output. It was around 350 to 400 ml. Patient was passing flatus. So we started now giving her enemas. The reason to give enema is that colon should be empty and everything should come out. If there is a large ficcolith in the colon and if the enteric contents are not going ahead, the fistula output will be high. So you have to keep the distal passage open. So we started giving enemas to the patient and we asked her to take orally sips now. So again, by giving creat came down, hemoglobin improved, albumin was still 2.5. Then we did the anatomical assessment of the fistula. If you see this video, you will see. So there was a leak of contrast. This was the oral contrast which was given. There was a leak of oral contrast somewhere just in the proximal ileum, distal jejunum or proximal ileum, and this oral contrast was coming out through the midline wound directly. I'm not able to fast forward it. I'll just show it as soon as it comes. So this is the stomach. As the stomach goes down, we'll see the enteric. So this is the small bowel jejunal loops. And as the jejunal loop go down in the proximal ileum, this was the leak where the enteric contents were coming out through the wound. So that was the anatomical assessment we did. We understood that fistula is somewhere from the proximal ileum. So on 10th of October, this is the post-operative date in the primary surgery which was done there for perforation. Patient pulse was stable, BP stable, she was afebrile, now respiratory rate was 20, and over a period of next 4 days, as we started giving her enema, the fistula output again came down to 200 to 250 ml per day. She was passing stool, small amount, and taking 500 ml liquid. Now in an ideal scenario, I asked the patient her hemoglobin improved, albumin went up to 2.9, rest of the things were normal. So my plan was actually to progress her to high protein liquid diet and discharge the patient with that bag and ask her to come back after 14 days. The reason being she was improving, the fistula output was coming down, there was no fever, she was maintaining nutrition a little bit. And if there is no resolution in this, the fistula after 8 weeks, then we'll plan the surgery. But then there are many factors which come into picture, like a patient is from a remote area from Madhya Pradesh. They don't want to carry that bag along with them to home. They have financial issues in form of parental nutrition, which is already going on for 8 to 10 days. So somewhere in such patients, we have to take a risk. We have to explain and then re-explore the patient. So at 18th post-operative day from the primary surgery, after building her up, we explored. So there were interbowel adhesions, clumping of ileal loops. Leak was there at ileoileal anastomosis. We didn't know what the primary surgery was, but it was a proximal ileal leak. We did adhesiolysis, ileal segment resection was done, and we did side-to-side ileoileal anastomosis. Now we had an option of creating a stoma, but then a proximal ileal stoma would have been again a disastrous or a problematic thing for her, considering a large amount of fluid which will come out. She will land up with electrolyte imbalance and all. And we kept a wide drain. So the principles are drain all the collections, careful adhesions has adhesiolysis, because you don't want to create further enterotomies. More enterotomies you create, more are the chances of leakage again after the surgery. Avoid enterotomies, as I said, avoid serosal trier. Try to make stoma if it is possible. If it would have been a terminal ileal, I would have definitely made a stoma. But it was a very proximal bowel, so we avoided a stoma and keep wide bore drains. So post-operatively, she recovered very well. She was started on liquid on day 6. And she continued to have fever after surgery actually. USG was not showing any collection. She was treated with antifungal agents and was discharged on post-operative day 10. So this was one scenario in which we managed the initial sepsis part, resuscitated, built her up nutrition. We wanted her to go home, but because of some reasons she could not, and then we had to operate. Coming to just a short case, other scenario. This is a female who underwent dermoid cyst surgery on 18th August. Fecal contents were there through the wound on day 3. So rectal perforation was there as per the primary surgeon. So they did the closure on 21st August. And then on day 8 of this surgery, that 29th August, they referred us the patient with again fecal fistula. So on presentation, patient was septic and malnourished. But if you see this CT, you will understand what is going wrong here. So there was a large subhepatic collection here, subdiaphragmatic collection, as you can see, and large perisplenic collection also. So this patient on presentation had sepsis, malnutrition, and there were dense intra-abdominal collections. Now we need to drain this collection to take control of sepsis. These cannot be drained percutaneously because there were multiple intra-abdominal collections also. So in such case, we had to go in immediately. So we explored the patient, we gave good lavage, we closed the rectal perforation, made the stoma. Within 3 to 4 days, patient improved out of sepsis. Stoma started functioning very well. She was discharged on day 8. And in December, we closed the stoma. So this is another scenario where you have to take care of sepsis. And for taking care of sepsis, sometimes you have to go in immediately. In first scenario, there was no tenderness, there was no collection. But here, there were dense collection which could not be tackled with pigtail. Coming to just one slide, this was the patient I had seen way back in August 2019. She had past history of meshplasty and was operated for obstruction. There were dense adhesion to mesh. Small bowel resection and colonic resection anastomosis was done, and then she had fecal contents through the wound. So we kept this wound manager back and we followed SNAP for 4 months in this patient. Now this patient was from Nagpur. She was from well-to-do family. The relatives were very well counseled and they were ready to take care of the patient at home. She was in hospital for 1 month, and at 3-month follow-up, this was only the small hole which was left, and that was the fecal output which we could see. Earlier, the whole bag would fill for 200 to 300 ml. By end of 4 months, it was only 40 to 50 ml. So this was a classic SNAP regimen which we followed in this patient. And later on, after complete healing of this wound, we went in with surgery in which just a colectomy was done. This surgery was actually done in Hyderabad. They wanted to go to Hyderabad, so I sent her there. So this is a classic SNAP in which if everything is acceptable to the patient, relatives, finances are not an issue, we'll wait for like 4 to 6 months and make the fistula heal. So intracutaneous fistula, majority of the times it is iatrogenic because of enterotomy during the dissection or anastomosis leak in nearly 75 to 80%. Sometimes it may happen because of diverticulitis, inflammatory bowel disease, or post-radiotherapy. We have two categories, like a fistula output which is more than 500 ml or a low fistula output which is less than 500 ml. We also categorize fistula depending on the site of origin, like pancreatic, duodenal, enteric, colonic. The closure rate, spontaneous closure rate is only 20 to 30%, and 90% of these will happen within 4 to 5 weeks, and next 10% will happen up to 8 weeks. If the fistula has not healed up to 8 weeks, then that patient is going for surgery. And mortality is still 5.5 to 33%. And what are the factors which are favorable for fistula closure? I'll just enumerate fast. So a fistula tract which is long from the bowel to the skin, if the fistula tract is long, it has got very high chances of healing, because any point it gets fibrosed and closes, the fistula can heal. A single tract, a lateral fistula. Lateral means if it's an end-to-end anastomosis and it has opened up, the chances of that fistula getting healed is very less. But if it is a small enterotomy in a bowel in a lateral wall, then chances of that getting healed is very high. A non-epithelialized tract, by 6 to 8 weeks, usually there is a epithelialization which happens from the enteric to the skin. Jejunal, colonic or a duodenal stump fistulas are good to heal. Then there should not be any intestinal disease like Crohn's or diverticulitis, as we know. Abdominal wall should be intact. A patient should not be malnourished, and there should not be any sepsis. Then there are very high chance that these patients may improve, or the fistula closure might be there. This is one acronym. Friends are actually foes for enterocutaneous fistula. So if you have any of these, the chances that the fistula will heal are very less. That is presence of a foreign body, presence a fistula which happened in background of a radiation, if there is any inflammatory bowel disease or an infection like an abscess cavity near the fistula, epithelialization of a tract, presence of neoplasm in the fistula itself, any distal obstruction as I earlier mentioned, or the patient who is on therapeutic steroid. These are very poor markers in which the fistula will really heal. Some of the non-clinical aspects which we textbook never describes is the counseling of the relatives is very much important. Patient himself and the relatives who are seeing a bag which is getting filled with enteric contents daily, and we are just saying, don't worry, don't worry. We have to sit with them, we have to explain them the disease process, how much long it is going to take, how much finances it is going to take. And that is the most important part. If the relatives are very much affording, and if they are very much okay to take care of these things, then chances of getting good fistula closure rates are high. Of course, they may have financial issues because wound care, back, parenteral nutrition, and even hospital stay becomes costly thing for these patients. So this is just a sentence from Bailey. I have taken up: an early return to theater to try and fix the problem in a septic malnourished patient is doomed to failure. So for an enterocutaneous fistula, follow SNAP. Thank you.
Very nice. Only one thing I have to add: if the fistula is near the sphincters, like ileocecal junction, it was far away.
Yeah.
Always, I think we should reset the sphincter.
Yes, sir.
That is
So a 10 centimeter resection, which we talk of, rather than doing anastomosis in the terminal ileum 10 centimeter, it's better to do a ileocolic anastomosis rather than keeping that
That is
sphincter
always
flat.
better. Or
Yes.
otherwise bypass iliotransfers.
Yes, iliotransfers bypass. Yes, sir.
That is good.
Yes, sir.
And SNAP is always better.
Yeah.
Sharing the experiences, most of the ileal fistula, if the distant tract is patent, closes spontaneously if the
Yes.
patient's condition is good.
Yes.
Intervention is very rarely required unless until patient is in sepsis.
More distant the fistula is, more chances of closure. Like if it is a colonic, all the more chance that it will heal on its own, because most of the contents are absorbed by the colon itself. The amount of enteric content which comes out is very less. So chances of these fistula getting healed are good.
And first intraoperative sepsis is only 3 to 7 days. That is the stage of cellulitis.
Yes.
Where the highest mortality is there.
Yes.
Once that 7 days goes away, then we can start the oral, no problem.
Yes, sir. Yes, sir. As soon as the patient abdomen is soft, patient is feeling hungry, we should start feeding them.
Only the patient dies in cellulitis stage.
Yes,
Because of septicemia.
early 7-8 days. Yes. Okay.
If no more questions, thank you, Yogesh.
Thank you. Thank you.
All the cases were fantastic. We had a wonderful time chairing all the sessions.
So I thank my chairpersons for accepting our invitation to be the chairperson. today for this 103rd Midas Clinical Meet. I thank Padole sir, Singhania sir, Amit sir, and Dr. Pratik Padole for being the chairpersons here. I also thank online chairpersons, Dr. Rajesh Kumar Patel, Dr. Shivaji Thakre, and Dr. Pankaj Ingre. I thank the audience for coming in large numbers today. I thank my speakers, Ravi, sir, Mukivar sir, Atul, Bhushan, Saurabh for presenting excellent cases. Now I invite you all for dinner. Thank you.
Thank you.
We have online chairperson, Dr. Pankaj Ingre, Dr. Rajesh Kumar Patel, Dr. Shivaji Thakre. Would like to have some comments from you all. Dr. Shivaji Thakre is visible online.
Yes, sir. It was a very nice session, sir. And very glad to chair the session. And cases are very, very nice.
Thank you.
Thank you, sir.
We have Dr. Rajesh Patel also. We can see you, Dr. Rajesh. If you would like to speak something.